Peptides are everywhere right now on social media, in clinics, in conversations about healing, performance, and chronic disease. But as interest explodes, so does confusion. Are peptides powerful tools for restoring health, or are they oversold before the science is ready? Tonight, we explore where peptides truly fit in medicine, what they are, how they work, where the evidence is strong, and where caution is still warranted. Welcome, everyone. I'm Dr. Kristina Carman, IMA Senior Fellow, and this is the IMA Weekly Show produced by the Independent Medical Alliance. At IMA, our mission is to bring honest medicine back into healthcare, evidence-based, ethical, and centered on informed decision-making. Tonight's conversation is a deep clinical dive into peptides, not hype, not shortcuts, but real world experience, emerging science, and thoughtful responsibility. I'm joined by two amazing physicians with extensive hands-on experience using peptides in clinical practice. We have Dr. J.P. Saleeby, is an IMA Senior Fellow in Functional and Integrative Medicine with extensive experience in metabolic health, inflammation, and complex chronic illnesses. He serves as medical director at Carolina Holistic Medicine and is the core contributor to the IMA I Recover treatment guide. Dr. Saleeby brings system-based, terrain-first perspective that directly informs how peptides are used responsibly in clinical practice. And we have Dr. Bahnmiller, is an OBGYN and medical director with over 25 years of experience even in oh my goodness, my words, obstetrics, gynecology, surgery, and hormonal health. Fellowship trained in hormonal and sexual health, Dr. Bahnmiller focuses on optimizing hormonal balance and tissue healing across all stages of life, bringing in clinically grounded, evidence-based lens to peptides use in practice. So together, we'll clarify what peptides are, where they are most useful, and how to think about them responsibly as part of modern patient care. So, a big central question: how peptides fit into ethical, evidence-informed medicine today, and what role should they play for our future care? So peptides are everywhere. I'm going to open the stage into first comments and thoughts on how they really should be used, and popularity on social media and longevity circles, and increasing the use of peptides in clinical practice as well.
Well, I'll start off. I'll warm up the audience. So I think really a golden rule would be to use, like everything else in medicine, to use peptides carefully and cautiously. They're pretty much new to the West. If you look at the history, they've been researched pretty heavily in the former Soviet Union. They're probably 2, 3 decades ahead of some nations as far as research goes and data. But it's fairly new to America, considering. And I think take baby steps and get familiar if you're a clinician wanting to start administering peptides. Pick a few, pick 5 or 10, get to know them very well before you start prescribing the hundreds that are available.
Yeah, I completely agree with that. The one thing is, I think we have to kind of step back a little bit too and kind of define peptide because it's kind of like a trigger word, and people like peptides is like new and great. Well, insulin is a peptide. So when we look at it, a peptide is basically you break it down, proteins, amino acids, your building block, and then peptide is basically a small group of those, typically less than 50 amino acids that trigger an action in the cell. So we're not recreating the wheel. We're basically starting to learn and understand new ones. And there's a lot of hype because the advances that we have in peptides, especially since the GLP-1s came out. Therefore, I think a lot of times we kind of knee-jerk reflex and try to, oh, we want to fix everything as docs. I understand that. But at the same time, we have to say, okay, what's really going to help this person? Where are we overselling, or where we got to use stuff that actually has a reasonable science behind it?
Yeah, I love that. And actually, it kind of segues into my next question and maybe some questions from our audience as well on, one of the things that really is often highlighted in peptides is that it acts like a signaling molecule, and that's what you just certainly mentioned. But clinically, why does that distinction matter? And maybe we can do like a little high level definition on what exactly a peptide does and how does it differ from, I don't know, a nutraceutical, for example, or something else that you might be taking, pretty consistently.
Well, I guess by the classification, if you want to look at, drugs versus biologics versus dietary supplements or nutraceuticals, it would fall into that dietary supplement nutraceutical family, especially the ones that are available over the counter without prescription. Now, if they're prescriptive, like Daniel said, insulin, oxytocin, those are peptides that have been used by doctors for a long time, and a lot of them are prescriptive. Um, but there's an emergence of a lot of these ones with weird names and nomenclature, like BPC 157 or MOTS C or CJC. So that can be confusing and daunting, and it looks like brand new and exciting, but you can get in trouble if you don't understand how they work. And they are like messengers, just like steroid hormones can be messengers, like your testosterone and your progesterone and your thyroid hormones can be messengers. Peptides are too. They're very small chains, sometimes as few as 3 amino acids long and up to about 40 or 50. And as messengers, they're maybe a little cleaner than steroid hormones. Of course, they use different pathways. They trigger a response to start a certain pathway, and using multiple ones in conjunction can be complementary and synergistic.
And I agree. Yeah, I think that's a good definition. I mean, a way to look at it. Uh, when I look at it too, is that, you look at nutraceuticals, like, you get a lot of patients that come in that have take a ton of vitamins, which great. But sometimes we kind of overdo it and we're trying to fix all these different things. We're not really understanding the pathway in the patient and saying, okay, what things need to be done to optimize the utilization of peptides? If somebody's not getting proper health care or not taking care of themselves, exercise, um, sleep, things like that, they're not going to function well. And so you're basically throwing a lot at the vitamins, like you're saying, nutraceuticals or such. They're usually essential things that the body needs. These are more messengers to kind of direct the body on how to heal or how to process things or to help the body regulate things. So, you know, for example, if you had somebody's giving a guy a message to grow a certain way. Well, if he doesn't have the right things, the right nutraceuticals and the right protein, right other things that it needs, it's not going to do anything. So they kind of work hand in hand. So, but the big thing is, I think a lot of times we just like, hey, let's give you this and it's going to fix your problem. That's kind of almost a problem that traditional medicine got in trouble with because they're like, we're going to fix it with drugs. Well, the drugs don't work if we don't take care of the patient.
Yeah,
Right.
absolutely. And it's
I,
again looking at that foundation, the terrain, right? So if the basics almost need to be addressed as step one, and then layer in all the other supportive things because it just heightens their efficacy and how they work in the body. Is that sort of, am I understanding that correctly?
Yeah.
Yeah.
Yeah, you can't skip the fundamental foundational things like good nutrition, exercise. There are some that are exercise mimetics or sleep mimetics. And you can't just island hop over that fundamental stuff. The stuff, Christina, that you teach your patients, about good nutrition and diet, the proper supplements, the right amount and right type of exercise. You can't say, well, I'm going to sit on the couch and watch Netflix, but I'm going to pop a couple of peptides to make up for that. That's not the way to do it.
I'll give you a perfect example is with the big surges of GLP-1s, even though they've been around for over 10 years, is that people think, oh, I'm going to lose weight. Well, the thing is, they don't have the proper amount of protein, they don't have the proper hormones, so they lose muscle mass if they just do that. So that's an improper use of the GLP-1s because all of a sudden you create a problem. And a huge study came out showing that people that do that and then stop, they rebound just like somebody that had stomach surgery to reduce their food intake. So we really got to focus primarily on diet, exercise, sleep, and then listen to the patient, see, okay, what things really are they missing, and see, okay, how can we fine tune it to optimize their health now and in the future?
Right.
Yeah. So, and I mean, in a scenario like that, the coaching element is so important to sort of guide patients through how are we supposed to use these correctly so that actually we're, it's not a waste and it's actually optimizing the health, not hindering it long term, right?
Yeah.
Right.
So I suppose my question is, if, from your perspectives as physicians using peptides in your practice, what do you think has really shifted over the last 5 or 10 years, that has brought peptides more into mainstream? I mean, I think we probably touched on it a little bit, but why the sudden, I guess sudden, but popularity around it, and how, you know, I suppose how is it even misunderstood even within our medical community with doctors using it or being adverse to using it, and in that kind of setting?
I think the big surgence of it is kind of related a good part to the GLP-1s because before people struggle with weight loss. I mean, that's just human nature in our country. But then you throw a GLP-1, everybody knows that, hey, all these people that couldn't lose weight lost weight. And so you get the excitement around it. And then all of a sudden you get the body image excitement as far as building muscle, things of that nature. And then it kind of just stems from there, which is great because I think it brought a lot of attention, a lot of excitement. But then it also brought with it people on the fringes trying to oversell stuff that's really we're not sure. We have a good idea, may help that or do that. And it gets into more stuff where JP would have to talk about more than neurological side, which I think is exciting, but it's kind of like one of those things. It's like you get something and people want to run with it.
Right. Yeah, like the fear with you're right, Daniel. I believe that the GLP-1s has just put everything on turbocharge, and people don't realize that, the weight that you lose is both muscle and fat. And obviously you can't be on those forever. So when you stop, what's happening is folks are gaining all the weight back, but they're not gaining the muscle back. They're gaining fat. So the ratios of muscle mass to fat mass is not ideal, and actually you're in a worse spot. So you can jumpstart your weight loss program with a GLP-1 agonist, but you should not be on it for, at least in my practice, I don't put patients on it long term. That's a bad idea. And we then during that time get them on some healthy lifestyle choices. But there are some really good cases, and I will have to say that not all peptides work for all my patients. I have had some major failures. I mean, I have, cases where it's amazing, and had averted surgeries. And then I have cases where we tried different rounds, different courses, stacked them, pulsed them, and they just don't work. And I wish there was a magic test that you could do for determining if one is going to work or not, because they are expensive.
Mm.
Um, and I think there's an emergence of some of these peptides with some research, especially on Alzheimer's and dementia, that's kind of exciting. But again, we're not going to have some immediate answers with that. It's going to take some time to accumulate some good data on whether they are fulfilling the hype behind them.
So you really can't tell, like, for what certain patient a peptide would work for versus who it would not work for. There are situations where it's certainly not the right tool. You wouldn't use that, but you, how do we know almost like who it would work for and who it doesn't? Have you any insight into that?
Well, I think if you're well, you probably don't need peptides. But I think the emergence of um, biomarkers in medicine now, inflammatory markers and things of that sort, is maybe driving the use of peptides a little bit more. Two couple decades ago, we never measured HSCRP on folks. Now we can, MPO, LPPLA2. And if they're elevated, you're going to say, hey, what can we use as an anti-inflammatory? Where you're not going to put your patient on ibuprofen every day. That's a bad idea. So you're looking at alternatives for what can reduce inflammation. And there's some very good peptides out there that reduce inflammation. You may look at folks that have orthopedic issues and they've tried PRP, they've tried stem cell, they've tried other interventions, and they've got knee replacement looking them in the face. And I have a case that was one of the first peptide patients I ever dabbled with as a long-term patient of mine. This was pre-pandemic, and she was facing bilateral knee replacement surgery, and she was mortified. So she said, "What else can I do?" And I said, "Well, you've done about everything else under the sun. We can try peptides." So I put her on BPC 157 and TB4 frag, and she did a 2-month course. And I saw her many months later, and she had lost 60 pounds because she was able to go to the gym. And she said, "Guess what, Dr. Saleeby? I canceled my surgery."
Mhm.
And I spoke with her not too long ago, about 6 months ago, and she's only done that one course. It was a 2-month course, and she's maintained her bone health. She's pain free, and there's no degenerative changes in her knees anymore. I was floored. But now I've tried that combination on other folks with hips and with other situations, and it doesn't seem to work as well. So it's kind of a hit or miss thing.
And I agree. I think too, you get a feel for your patient. Um, Over time, after you kind of utilize peptides, yeah, it's hit or miss, kind of trial and error. But then you kind of get a sense, okay, this person it'll work well on or not. And still, even then, you miss it. But that's the art of medicine, in which I think a lot of times we kind of miss when we're like doing all these tests and focusing on, oh, it's this marker and we're going to use this. That helps, but it's not really true thing. And even when I can do hormones, most of my stuff is listening to the patient and kind of tailoring the hormones of that and using the lab to say, okay, we in a reasonable range to kind of what we're doing with it. Um, but then the other big thing, and I like your case because a lot of times too, what we don't appreciate when we do weight loss, people think it's losing fat. It's really our metabolic organs are muscle. And if you build up muscle, and if you, studies over and over show if somebody has healthy muscle mass, they're healthier even if they're overweight than somebody that's ideal body weight that's has bad muscle, doesn't have much muscle. The muscle is a metabolic organ, and so by increasing your metabolism, you're decreasing inflammation. So you're going to get less joint pain, you're going to have less neurodegenerative disease, and really the peptides are kind of helping with that. And I mean, I'm not as big an expert as JP on neurodegenerative disease with peptides, but from a women's health or hormonal side, we see a lot in studies that show the better muscle mass we have going into weight loss meds like GLP-1s and such. Um, and the more we can maintain muscle mass, the better they're going to do with their weight, but better their overall health. And when you look at sexual health, it's a huge difference, because things that we use there are much better. The peptides we use there work much better when we can decrease inflammation and keep their metabolism up.
So it always comes down to even like your baseline health picture makes a huge
Yeah.
difference on even the peptide's efficacy. Yeah, that's really interesting. And then like for clinicians, for example, who are new to peptides or would be interested in, kind of exploring that, what would you say would be the most common entry points you would see? Is it injury repair, inflammation, metabolic health, or where would you start?
I agree with JP that pick 4 or 5 that really interested me. It's hormones and sexual health. So I use more on that end, and I get, I kind of start with a few, build up, get very comfortable with it, in the stuff that, and be consistent with what you do and build from there. I mean, I'm much more on the side of hormones than I am on neurodegenerative. Yes, they cross over, but I'm not going to say, hey, I know. If I had something like that, I'd send it to JP. I'm not going to take on neurodegenerative. Yeah.
So
Yeah, I think
stick in your lane, right? Stay in
yeah.
your lane, scope of practice.
So I don't know if, like me, there's some patients that I have dealing with severe chronic illness and very complex patients with, long COVID and maybe Lyme disease and, mold illness, whatever. And I'll usually break the ice on the peptides with them. We've tried a number of things, and I'm like, okay, now we're going to segue into maybe some healing peptides that might help. But then there are a class of patients that are coming into the practice that are asking for them. And these are usually biohackers. These are the folks that are the anti-aging, very, very interested in maintaining their physical appearance. They don't like wrinkles. They don't want to do Botox, but they want something maybe better, safer. And then there's those combination of peptides I think we talked about on the last episode. We talked about peptides like the Wolverine or the Glow, GLOW, or Clo peptide combinations for aesthetics. So you have that crowd. You have to be careful with them because they've already experimented. since you can obtain peptides online without a prescription, a lot of them, are injectable, and that turns people off. So they'll try to look for the mouth sprays or the oral capsules that, in my opinion, aren't as effective, but they're a good entry point for people. But they've experimented and they come in with a big fund of knowledge. So you have to prepare yourself and study them if you want to give advice to folks in your practice.
And I think too, we don't want to forget taking care of just their good basic health like you do. Uh, as far as with, diet, exercise, but you do that. I take care of their hormones before I'll step into peptides because otherwise, I take care of a lot of perimenopausal, menopausal women. And if I don't get that right, nothing else is going to follow suit. Then I'm using ones that work with that I know. And then there's ones that people come in like JP is saying that they're biohackers. They know everything under the sun. And you got to kind of like figure out, okay, what things can we step into that are you're very comfortable with to then sometimes you do step into things like, okay, from what I can understand, this works well, let's try it.
I'd love to talk a little bit more about, exploring peptides in neurodegenerative conditions. And maybe Dr. Sleepy, you can speak to this a bit more, but what's most compelling to you in this area in particular?
Well, it's still rather new, and it's kind of very exciting because it could be very useful. Any truthful neurologist will tell you that none of the pharmaceuticals out there for dementia, for Alzheimer's disease, are very effective. Aricept and Memantine and things like that aren't very good. They can slow down um, the degenerative disease of the brain, but not likely to reverse it. It's basically once you're diagnosed and it's rapid, it's kind of a terminal illness. So there are some peptides that are useful to reduce neuroinflammation, and I think that's the keystone, if you will, of the dementias is inflammation of the central nervous system. So things like CMAX and CLANC, things like um, TB 500 is kind of at the tip of the spear now these days. There's a lot of research and a lot of interest in using thymosin B frag or TB4 frag, also known as TB 500, as a something to help reduce neuroinflammation. There are some others. I think I would probably bore the audience by rattling off a bunch of names, but there's some basic ones too, thymosin alpha 1 or TA1. And when I mention that, I should probably mention, as we did pre-show, that there may be some issues with obtaining it or physicians prescribing it or compounding pharmacies making it. So back in 2023, September of 23, the FDA came down pretty hard on about 17 different peptides that were being created in certain pharmacies. There are certain levels of compounding pharmacies. Some can manufacture, some can do per patient prescriptions of sterols. And one on the top of the list was thymosin alpha 1 or TA1. And I think it was a consequence of people coming out of the hospital after COVID and having COVID lung. All right. So they survived COVID in the hospital. They were probably intubated. Anyway, they survived all that, came out, and their lungs were a mess. And some clinicians were using TA1 sub-Q to fix that. And there was resolution of their pulmonary issues. And I think that didn't agree with the narrative. So the FDA banned that immediately. It wasn't taken seriously. And then about a year later, they came back and said, look, we're serious. If you continue to compound these 17, then you could face incarceration and really hefty fines. So that really put the brakes on some compounding pharmacies really not doing that. But they're still available for research purposes and for veterinary use and things like that online from different reputable companies. And you just have to instruct your patients about, being careful what they choose, where they get it from. So I typically don't write a prescription unless it's one of the ones that like Pineleon or oxytocin or insulin. Those things I write for. The others I recommend, but allow the patient to obtain them on their own. Um, so again, I think you'll see in months to years to come, neurodegenerative disease addressing peptides and other drugs as well. But it's a shame that for many years now we've had only a very few drugs that are prescribed for Alzheimer's that aren't very effective. What's more, and this is another show, is the vast number of drugs that are being prescribed to our patients that cause dementia,
Mm.
anticholinergics and a whole host of psych meds that will actually make a problem worse. So you have to have a reasonable doctor to get you off of those things and then maybe implement peptides.
And in conditions like Parkinson's, for example, where it's mitochondrial dysfunction, inflammation, and maybe the neurodegeneration kind of intersect with each other, would peptides be looked at or explored? Do you have any experience on or any research coming out in those areas?
Oh, absolutely. So a lot of peptides really help with folks with mitochondrial dysfunction, whether it's Parkinson's or other muscle wasting or failure to thrive kind of situations. People with a lot of chronic illness, long term have mitochondrial dysfunction. I mean, I could take a history in 10 minutes on a patient and realize their mitochondria ain't working real well, and I don't need any fancy mitoswabs or mitome testing. I mean, you can tell from their history before you even get the first blood work. But there are some mitochondrial enhancing peptides. 5-amino 1-MQ is one. MOTS-C, MOTS-C is another. There's another one called SLUPP332, FOXO4, and some of these are also used by the biohackers for longevity. CJC is one, ipamorelin is another. And most of these are injectable or subcutaneous injection, but some are gut stable and can be taken orally. And again, that most patients would rather swallow a pill than have to inject themselves once or twice a day. And but there's some really interesting peptides. I'll bring one up because it's so cool, and I'm starting to use it a lot on my folks that have insomnia, that where nothing else touches them. So intractable insomnia. There's one called DSIP, Delta Sleep Inducing Peptide, and you can give it 3 hours before bed. Loading dose is like 100 mics, and then maintenance is 50 mics per day. That helps people induce their delta sleep waves, and they'll go to sleep where other things don't work. And that's not, I don't start off with that. I'll start off with, other things. And Christine, I know you prescribe a lot of herbals and things to calm the nervous system, maybe GABA and things like that, saffron and other sleep aid, chamomile teas and things like that. That's where I go first. Melatonin. Occasionally I'll use some trazodone, lower doses. But if none of that works, I'm not a big Ambien fan, so I'll put DSIP before Ambien, okay, on my patients. But so there's calls to use different type of peptides for different reasons. There's some that are stronger, but one peptide is not just focused on one body system or problem. I mean, sometimes you can use one peptide that covers lots of different disorders and is very useful and helpful in folks with the different types of diseases.
So it would really depend in that kind of scenario. You look at the patient in front of you, or you look at whatever their symptoms, their condition, their queries, even their goals, and then you would make the call at that stage, um, where you would go as far as using peptides. Would you even use them, or would you obviously look at the foundational things first? Those being, I mean, certainly from my perspective, full stop have to be number one.
Mhm.
But then it would be very much a call at that stage where you would go as far as what peptide you use based on what their outcomes are, or what you want their outcomes to be, essentially, or even the
Right.
patient's outcomes, right?
Well, typically, if let's say it's an orthopedic problem, they've got a bad shoulder, rotator cuff issue, or they've got bone on bone issues or cartilage degenerative diseases and neurodegenerative joint disease. BPC 157 paired up with TB4-FRAG is where I would start. I wouldn't use MOTS-C on them. I'd start with those. There's been a lot of research out of former Soviet Union back in the day during the Cold War when they were trying to, one up the West. So their athletes injured on the field, they would actually inject BPC 157 into the injured tendon. And that athlete would be back up on the field of play within a few weeks. Whereas in the West, they would have to have surgery, a cast, physical therapy, and they'd be off the playing field for months. So that was a lesson we learned from our brethren over there in Russia. And the KGB would do something bad to you if you tried to leak that stuff out during the Cold War. But now it's borders are open and the Iron Curtain's down, and all that information has come to the West. So it's very interesting. But let's say if it's an insomnia problem, I'd go for either oxytocin or DSIP. If it was anemia, let's say they had a hemorrhage problem and they're trying to build their blood back up, there's a peptide called PT141 that's helpful in building up the blood counts as well as sexual health. It helps with folks with sexual dysfunction. So it depends on the patient. And one thing probably worth mentioning, it's not as common a term, but it will be, is bioregulators. So they're very much like peptides. They're a little bit different, but there's a fellow who's introduced a lot of peptides to America, Kent Holtorf, and he's come up with some formulations that are called bioregulators. And in a recent webinar he was talking about maybe using those first, and a head start with bioregulators before you start using peptides. So again, it's very complicated. There's a lot of nuances here and caveats, and it's something that the person out there should not do it yourself. I think that's dangerous and can get you in trouble. And as we mentioned in a previous webinar, there are a few peptides to avoid if you're fighting cancer. And there's some that are helpful if you are fighting cancer. So there's a lot to it.
Dr. Bahnmiller, I'm really curious to see how you would use peptides in a hormonal sexual health setting. I'm fascinated with that area. I do a lot of work in women's health, so I'm interested to see your take on how would you layer that in?
So, I mean, JP brought up about PT141, which is actually a medication called bremelanotide or Vyleesi is a brand name. That one's a pretty common one we use. The interesting thing with that one is it kind of goes back to understanding what your peptides are doing and kind of for example, in the UK, they use a lot of it for skin darkening. So they want to look like they're suntan. So they'll overutilize it because one of the side effects of bremelanotide, which is a melanocortin stimulating hormone, is that you get darker skin. So, but the nice thing is that we utilize it a fair amount for decreased desire because it does increase your bremelanotide in your usually in your linear nigra, so that way you get increased stimulation and increased desire in women. So that works well. The thing is that where I always go back to the foundation, not just diet, but hormones, because really, if you don't have a good baseline with your testosterone, estrogen, you kind of, if you just do PT141 or bremelanotide, they really don't get a good response. And the same thing too with like you're mentioning about injecting into ligaments and tendons. We have to also appreciate when we're 20. The big thing I'm big into hormones because when you're 20, your testosterone is at its peak. You hit 40, you're about half where you were at 20. And testosterone is huge, not just with muscles, it's also huge with joints, ligaments, and inflammation. So you can inject all the peptides you want. And, I don't do that in joints because that's not my forte. But really, if you get their testosterone well, a lot of times they improve. And then you can kind of look at what you want to add in. But our big one is PT141 for desire. There's not a lot of other sexual health peptides per se, because then they kind of branch off. The big one that we also use is going to be our GLP-1s and our GIPs because by decreasing that, we're increasing sexual desire because we're improving inflammation. But in sexual health, the more we can get their metabolism, get their back to a good health baseline, you're going to notice that they're healthier and they're going to be more sexually active and have more desire. So that's kind of where we look at it. And then as far as my big thing is sleep, and I use the same one JP. But then what you use, Christina, is actually the nutraceuticals. I use a lot of valerian root to get them in deep sleep because perimenopause and even before the 30s on, what you notice is that when your testosterone starts dropping, you get a shift in your cortisol. So we're not so responsive, and we make cortisol bad. Cortisol helps us, regulate sugars, regulate inflammation. You got to respect cortisol. And so when that starts changing and messes with our sleep cycle, then we don't get as much deep sleep. So that's why, when you get older, you look at your grandparents and they're waking up early in the morning at 2 a.m. and going to sleep at odd hours because that's off. And a lot of that is you can kind of look back as due to our decrease in testosterone. So if we optimize our testosterone and then we utilize nutraceuticals or where we're improving delta sleep, we get them in the deep sleep, then they're not going to have the brain fog. Then they're not going to have and estrogen too. But your first one that changes your testosterone, estrogen doesn't come along until probably mid 40s. That's when you see, hey, now women are having hot flushes, waking up hot or cold, and that's starting to affect their deep sleep. But it's testosterone with the cortisol first that changes that we don't appreciate as much in women as we do in men. And then we say, okay, let's get that stable and then start adding in like valerian root. I love valerian root. That's better for deep sleep. Whereas if you look at your melatonin and your I'm blank right now. Anyway, some of those are helping you get into sleep, whereas valerian root helps you get good deep sleep. I love it.
Yeah, I do too. I use also lemon balm. It's another one of my favorite ones.
Yeah.
But again, it comes back to like looking at getting the foundations, those important things right, because then it cascades into the next day. If someone gets really good sleep and they're sleeping well consistently, their choices in the day are fundamentally different to what they would be if they were sleep deprived and brains foggy and all of those things. So very, very different picture all around.
And their sex drive is much better too.
Absolutely.
Yeah,
Can we talk?
if you fix their sleep, 50% of their chief complaints go away.
Oh,
You
100%,
fix their
100% agree.
sleep, fix their nutrition, and you might not have to do anything else, you
Yeah,
know.
yeah, agree. I'd love to talk a little bit more about how to actually use peptides. So there's a lot of discussion around like, do you use one at a time? Do you use multiple ones? How long do you use them for? How do you sort of cycle them? Do you come off them, stay on them? All of that. So I'd love a little more insight on how all that works.
Well, I think you like to keep it simple, like this cake kiss. Keep it simple, silly, because it gets very expensive and it can be very complicated. But if you're not seeing results after 2 months with a single peptide, it's probably worth pulsing them or stacking them. You can use them in combination. Typically works better, more powerful response because they work in synergistic pathways. So some peptides will run a certain pathway or activate a certain pathway metabolically. And some of these parallel pathways will be synergistic. So you'll get twice the effect by using two different peptides than you would single by themselves. And there's no straight formula. I mean, you can be as creative as you want. You can stack them, you can pulse them. You do one for 2 months, then you move to a different one for a couple of months. Uh, the thing is with peptides, you shouldn't have to use them for too long a period of time, maybe maximum 6 months. With bioregulators, that even makes that even a bigger case. So bioregulators, you can have people on that. And they're usually organ specific, like for kidney or for retinas or for cardiac, heart. And those can be taken longer term. And then you can throw in a peptide on top of it for maybe 2 to 3 months. I rarely initially make the recommendation of a peptide for more than 3 months. If it's not going to work in 3 months, it's probably not going to work. So you can either add another or you can switch to a different peptide. Um, but there's all kinds of rationale for doing that.
Yeah, I
And I
suppose it's
agree with
important to note it's expensive, isn't it? They get really costly.
Hmm.
And I think, dude, keeping it simple because then you know if it works or not, and then stacking ones that are complementary. And I go with the same theory, just using it for 3 months because if it's not working by then, don't waste their money and time. We got to figure out what else is going on.
Yeah. And so what does from a clinician standpoint, when we're looking at, kind of pivoting more into the ethics and the safety and long-term use, I know uh, you know, there's a lot of things that we can do first. Obviously, we talked a lot, our protein intake and our nutrient status and blood sugar stability and all these things. What would be, is there I suppose my question really is like, what is the responsible peptide use look like from a safety and monitoring standpoint? If a clinician or even as a layperson wants to kind of dabble a little bit into peptide use, look like outside of obviously the foundational things that would be really important to address first. That's a loaded question,
That's
I
a that's
guess.
a huge question.
That's a lot. I honestly
I
think
think
you
you,
start with what you know and what you can find as far as set like that has good studies, good information and then build from there. And because you're going to get into gray zone, you're going to get into stuff. You're like, okay, we have good inclinations, works, but don't jump and do a whole bunch of it. Start with stuff and build from there. I think is the best way. And look at what research are because there is a good amount of it. There is good studies. So use stuff that you have some backing on first to say, okay, we know it does this. There's always a lot of gray, like, oh, we think it does this, but if you do start with that, you'll see with the patient, hey, it's helping with this. You know,
right.
I think just keeping it simple and building from what you know.
And a good example is a patient I had with leaky gut, and she had some dysbiosis, and we were working on cleaning up her gut. So I prescribed KPV. She did that for a while with minimal, improvement, and then I put her on a combo peptide of three different peptides. And it was funny because she never really complained about this resting tremor she had. She had a tremor in her hand and I put her on this triple peptide combination to help with her leaky gut. And after the third day, she calls me up all excited and she says, "You're not going to believe this, but my tremor's gone." And I'm like, that's interesting. I didn't even know she had a problem with it. She never really complained about it, but she noticed that it was, and she said that was the only thing I did different. She said, I've been on this peptide for 3 days and it's totally gone. And so I looked at the peptide combination. I said, you know what? They all addressed neuroinflammation. So while I wasn't directing my therapy towards, it was mostly towards her gut, it was kind of a nice collateral thing that it took care of her tremor. So and to this day she's doing really well. So
But also heal that gut and you heal so many other areas, right?
right.
I guess last kind of question that I want to wrap up with, and then maybe we can have some time for audience questions. But what's one sort of mistake that you wish practitioners, particularly that you maybe see within our communities, that they would stop making when it comes to using peptides with their patients, or even recommendations?
I think it's maybe a lack of knowledge on peptides, maybe prescribing them too aggressively, too high a dose, and for too long. I think if when I take on a patient who's seen another clinician who's dabbled in peptides, is that I kind of scratch my head and wonder, well, why did you do so many? Why did you do such a high dose? And why did you do it for so long? And usually one of the first things I do is stop the peptides that they're on because they've been on X or Y or Z for like, 6 months, 2 years, whatever.
Wow.
And I'm like, well, wait a minute, let's rethink this strategy. So that's the biggest qualm I have is that doctors need to, do a little bit more study.
And I think that kind of goes not just for peptides, for nutraceuticals, hormones, because how many patients you see that come in, you're like, they bring in a whole pharmacy of nutraceuticals and hormones, and I'm like, all right, we got to cut back on this. And kind of reset.
Mhm.
Okay, wonderful. Well, Autumn, do we have audience questions?
Hello, doctors. Yes,
Hi.
we have we have a ton of audience questions, so I'll just jump right into it. One of the questions, we have a few different questions on this, and I know you guys covered it briefly, but just the difference between oral peptides, topical peptides, and then injectable peptides. How effective are they? Do they vary in effectiveness?
Well, I can speak for from the sexual health of PT 141. There is an oral sublingual. If you take it oral where you swallow it, it gets broken down, doesn't work. If it's sublingual, it's somewhat effective. The best is going to be sub-Q, so injectable. So understanding the routes of administration, how they get broken down, just like any other medication or hormone that we utilize.
Yep. I have to agree. So there are some peptides, there's about a handful that are gut stable, so you can swallow them in capsule form. There are some that can be administered intranasal, like C-Lanc and C-Max, and those are great for people with migraines and that kind of stuff. And then there's sublingual dissolvable tablets or sublingual drops, like Pineleon is an example. And then there's some that are just plain have to be injected, kind of like insulin. You can't take insulin orally, so the gut just breaks them apart right away and they become useless. So they have to be administered subcutaneously.
I'm going to add to that. This is also very similar when it comes to using supplementation and nutraceuticals. Like the delivery and the form of how you're using it actually does matter depending on the person. Some people absorb iron better by using an iron patch or getting an infusion versus having it in supplementation. Using tinctures versus something that your stomach acid and digestion has to break down might be more effective. Liposomal delivery versus the other. So it again, it's very nuanced from that perspective, and it should really be individualized. It shouldn't just be throw something at someone and hope for the best. We need to approach it with care and understanding what would be the best option for that person where they are at that moment.
Well, even when you like nutraceuticals or peptides or even hormones, when you do like a testosterone cream, if you apply it on mucosal membranes, you're going to absorb much better than on regular skin. And then also on regular skin, and some people say, oh, inner thigh or outer thigh, those have different receptors for it converting to your dihydrotestosterone. So if you just give somebody a cream, they may use it in a place that doesn't work. And so
Mhm.
you got to understand what's the best mode of delivery and follow up with them to see is it working for
Mm.
Speaking of individualized care, like you were mentioning, Dr. Carmen, we had an anonymous attendee ask, is there a trusted resource list by condition or potential for peptides to evaluate / consider to reference? And then how does a patient evaluate these options with their doctor?
Hmm. Well, there have been a couple of pretty decent books written. There are some resources. Peptide Sciences actually has some resource. They have an ebook that goes over some basic peptide do's and don'ts and can direct people, both the clinician and the lay public, as to what maybe peptides they should start with. There's also Dr. Seed, who has written, I think, three or four volumes of books on peptides. So that's a good start. Yeah,
And I think like conferences like A4M is getting much better as far as presenting good, solid scientific data. And I mean, they're putting a lot into neurodegenerative stuff recently. So.
Sophie LaBelle asked, please talk about how peptides help with mast cell activation syndrome. Really great evidence that microdosing GLP-1s or GLPs help with mast cell activation, if any of you can speak to that.
Mm.
I treat a lot of mast cell activation in my practice as a consequence of COVID spike protein injury as well as chronic Lyme. It's said that about 20% of Americans actually have some form of MCAS, and it's not very well diagnosed because it could be anything from watery eyes and runny nose to all the way to anaphylaxis at the other end of the spectrum. but it's probably underdiagnosed. But there's a new documentary film on stealth syndromes and MCAS that's coming out soon. I don't really start with peptides so much. I use a fair amount of the traditional H1, H2 blockers, montelukast, some nutraceuticals that Kristina and I talked about, transitioning people away from singular montelukast to something safer. And also amloxanox is another agent that is very helpful in some of my MCAS patients. As a single agent, actually, it's probably, if they can tolerate it, it's probably the best single agent to use and can get rid of a lot of other drugs.
This is also kind of a huge generalization because it is very, very case to case dependent, but sometimes it's not. The MCAS is often activated or pushed into the scenario because of something else. So if there is some Epstein-Barr or some viral stuff going on, like what Dr. Saleeby has said as well with, unsupported Lyme, uh, this can really drive that scenario and that kind of picture. So it's worth investigating further what else could be underlying. And oftentimes there is something else there that could be contributing to the picture.
Another question that we got asked is, how can HCG be used? Can it replace testosterone therapy, or is it typically used alongside it?
So HCG, we've done it. We try to look at doing that. The thing is, when you look at testosterone production, testosterone, it's, you look at things like pregnenolone, you look at things as far as supplement DHEA, trying to stimulate more testosterone production. The problem is that it's the machinery that decreases. So you really get to a point where you have to supplement testosterone aside from HCG or using precursors to that hormone production. It's part of our aging process. We can't turn the machinery back on. Now, saying that, yeah, you can do it's not so much HCG. Really, what optimizes testosterone is simple things: early sun exposure, and you want to not have sunscreen and sunglasses on because that stimulates our body to make testosterone. Increased protein, 30 grams at breakfast is the best thing, not just for testosterone, but for muscle mass. It increases your growth hormone. And so 30 grams of protein at breakfast, early morning exercise, and early sun, and zinc.
Did you say not to wear sunscreen and
Yeah,
sunglasses?
for the first 20 minutes in your sun exposure, because it's ultraviolet A and B that turns on testosterone in our body.
Makes sense.
I mean,
There's some strong
normally, but
there's some strong herbs as well that can really support increasing testosterone. You've got to approach it cautiously, but definitely like tonkali, these ones can really increase testosterone. Again, approach carefully. But
Laura Chamberlain asked a question for the doctors. What are the best resources for scientific data on peptides? How about good sources for actual injectables? But do you guys have any thoughts on that?
I think there's some very good webinars in my circle and conferences that we go to that are heavily referenced. So some of the lectures that I tune in on. And then again, Dr. Seed's book is heavily referenced with really reliable evidence-based medical journal documentation. So it's just you have to hunt for it. You're not going to find it probably within the pages of JAMA, but hopefully maybe the Journal of the IMA will produce more articles on that. We can hope.
Yeah. Another question, lots of questions about what peptides can help with specific things that individuals are experiencing. And I know we covered this, Dr. Saleeby, on the last show that we did, more specific cases on what certain peptides can do for different issues. But We had a question on can peptides help with the healing of Parkinson's disease or Hashimoto's?
So for thyroid disorders, both Hashimoto's and Graves', any autoimmune of the thyroid, there are some bioregulators that may be more helpful than peptides. I'm a big LDN, low dose naltrexone, clinician, so anyone with autoimmune, I'm putting them on LDN and recently expanding on the use of it for pain control and depression and a few other things. It's really quite an amazing drug if used properly and prescribed properly.
Mhm.
So I would say I would lean more on the LDN for Hashis and maybe some bioregulators, like a thyroid bioregulator, actually, because they're pretty much organ specific. Um, but peptides not so much.
Mhm.
And I actually have had good success with like patients for LDN for other things aside from thyroid. And you also look at hair thinning and weight loss too. There's some individuals that do well with those.
Can peptides like DSIP, like you mentioned, Dr. Saleeby, be effective for someone who's trying to taper off something like ambient?
Oh, absolutely. Yeah, I do a lot of polypharmacy reduction in my office with my patients. And I'm mortified at the vast number of meds people come in on. And usually by when I'm done with them, they're down to one or two from like 20. And you realize that they've just accumulated them over the years. They've been to
Mhm.
different specialists, and this one will add this, and this one will add that, and then they add a third to take care of the side effects of the second one. And before you know it, they're carrying around a box or a basket full of pills, and it's really sad to see. And nobody kind of is there who is at the helm of that ship steering it. You got all these different subspecialists, and we take pride in our practice to do a lot of drug reduction. And you'd be surprised people do much better um, and feel much better, and then their pocketbooks show it as well. They're not spending as much money on these drugs. But
Mhm.
yeah, so there are some other things I would try first before DSIP on getting folks off of things like Ambien or sleeping pills or benzodiazepines and things like that. But you have to be careful. You can't come off of those too quickly. You have to do a nice, slow, steady taper off.
Um, Julie asked, what is the proposed mechanism of action for peptides in neurodegenerative disease?
I'd have to say the primary is anti-inflammatory. I mean, you can get it deep into the science of TNF alpha and reduction of this and that, different pathways, but it boils down to a reduction in inflammation in the brain. And that's good for Alzheimer's or different types of dementias and Parkinson's and ALS as well. Don't want to forget that.
Mhm. Last question I'll close with since we're already at the top of the hour. When medical and pharmacy boards restrict peptide use, is the real concern a lack of sufficient clinical evidence, patient safety risks, or is it that most peptides are federally illegal to compound? What are your guys' thoughts on that?
Well, I think it's you have to look kind of go where the money, follow the money trail. So pharma is not investing in too much research in some of these peptides because they are available without prescription. So there's not a whole lot of money to be made, but they will interfere with what pharma is trying to push. So
Mhm.
from that perspective, I think the old FDA, hopefully it's changed now, but the old FDA had was under the control and captured by pharma. So when pharma saw that TA1 was helping COVID lung, they did not like that, and that's why that one was banned. And I think the companies, the pharmaceutical industry that benefits from putting people on chronic medications for chronic conditions like osteoarthritis or MS or whatever it is, they have a lot to gain and a lot to lose when peptide therapy that's more readily available with even without a prescription gets in the way. So I think it was more marketing for pharma than it is true science. And they, of
Mhm.
course, they'll throw up, oh, it's for patient safety. Well, when the heck was the last time the FDA was so concerned with patient safety? I mean, we all learned that lesson from the pandemic. So I don't buy that argument. So there needs to be more science, that's for sure. Bigger studies for sure, but there is enough data to support its efficacy and safety.
Well, before I move over to our closing organizational announcements, is there anything that you guys would like to, any closing thoughts that you'd like to leave our audience with?
Oh,
Don't
Dr.
forget about the basics, guys. It's always about the diet, the nutrition, the sleep, the exercise, the sunlight. All of that can never, ever, ever be replaced by a quick fix.
Dr. Saleeby?
Yeah, I think if you're going to dabble in peptides as a patient, as a recipient of it, go carefully, go nice and slow and low. And if you're a clinician, study up. There's some good resources out there, like Daniel mentioned the A4M. There's the AMMG. There's a few other organizations, IFM, that will help guide folks in educating them. There's some great webinars also that are pretty legit. And so it's a matter of looking around and getting schooled up on it before you start throwing peptides at folks.
I agree with Christina. It's really got to go back to the basics. You fix the sleep, you fix a lot of their problems, and then you get them into a good diet. And really, a lot of neurodegenerative, like JP was saying, is inflammation, which is a lot of sugar, a lot of processed foods, and poor exercise, poor sleep. So you fix that, you're going to fix most of their issues, and then you can kind of start to work on adding the peptides in.
Well, thank you so much for hosting tonight, Dr. Carman, and for joining us tonight, Dr. Saleeby and Dr. Bahnmiller. I'm going to move over to our closing announcements since we already passed the top of the hour.
Thank you.
All right. Well, before we go into our closing announcements, we just wanted to let everyone know that we've been notified of some fraudulent accounts and websites impersonating Dr. Paul Merrick and falsely offering treatments and consultations. Update, we were fortunately able to work with the email hosting provider to have the fraudulent website taken down late last night. But there are still various accounts that are still up and active. If you come across any suspected impersonators, please report them immediately to us via direct message, or you can always email us at support@imahealth.org. Next week, well, firstly, IMA is proud to be a part of the Medical Freedom Act Coalition with 13 other organizations. And we hope that you'll join us for next week's show, Why the Medical Freedom Act Coalition Matters Now. IMA Senior Fellow Dr. Ryan Cole will be joined by Leah Wilson, attorney, executive director, and co-founder of Stand for Health Freedom, and Leslie Manukian, president and founder of the Health Freedom Defense Fund, for a critical conversation at the intersection of medicine, law, and health freedom. We hope that you'll join us Wednesday, February 11th, next Wednesday at 7 p.m. Eastern. This year, April 17th through 18th, we are hosting a medical education conference, Emerging Trends in Medicine, a two-day gathering dedicated to the latest innovations, research, and forward-thinking practices, helping to shape the future of healthcare. This event offers a dynamic program of expert-led lectures, networking opportunities, and hands-on learning through Abstract Alley, and much, much more. You can get your tickets at imahealth.org/conference, and we hope to see some of you there. Attorney Warner Mendenhall, a tireless advocate for health freedom. He's been on many of our weekly shows and webinars. He is a voice for the vaccine injured, founder of Freedom Council, and a close partner of the Independent Medical Alliance. He is now facing a battle with stage 4 cancer. He has sacrificed his practice, and he is having to self-pay for much of his therapy. You can learn more and help show your support at the link on screen, which is www.givesendgo.com/Warner. IMA is continuing to build a national trusted referral network, connecting patients with independent clinicians vetted for ethical and patient-first care. Your support helps fund platform development, provider onboarding, and public access so patients can finally answer the question that we hear every day: where can I find a doctor that I trust? You can support this work by donating at imahealth.org/donate. All right, well, that's all I have for you guys tonight. Thank you again to Dr. Carman, Dr. Bahnmiller, and Dr. Saleeby for sharing your expertise tonight and experience. And thank you to everyone who has joined us either live or if you're catching the replay. If this conversation was helpful, please consider sharing it so more clinicians and patients can engage in honest, evidence-informed discussions about emerging therapies. Before we wrap up, we wanted to share a quick video of IMA Senior Fellow and host tonight, Dr. Kristina Carman, in just introducing her comprehensive men's health guide designed for every stage of life. Whether you're in your 20s or in your 60s, this guide brings together the core pillars of men's health and prevention with practical insights to help support long-term vitality and well-being. Be sure to learn more and download the guide at imahealth.org under our Tools and Guides tab. Thank you all again for being here with us tonight, and let's take a look.
Hey everyone, today I want to share an incredible resource with you, the IMA Men's Health Guide. So whether you're in your 20s or your 60s, this is an incredibly comprehensive guide that's packed full of essential information that every man needs to really optimize health and vitality. So what's in this guide? Well, it covers all the foundational pillars of men's health and prevention. So we start to look at cardiovascular health, prostate health, hormonal health. We look at nutrition. We also included some information around preventative lab testing so you can really know what you're asking for, maybe understand your numbers. There's so much information in here, even around lifestyle strategies and some supplementation and really actionable steps that you can then start to implement right away. Download your copy today, and thank you so much as always for your support, and I really hope you enjoy this guide. It was an amazing project for us to work on as well. Thank you.